I'm Ann McCormack. I'm an endocrinologist, but I'm also run or head a small research group at the Garvan called the Hormones and Cancer Group. What it so far has meant for my clinical practice is that patients, particularly who present with some more unusual phenotypes or more unusual manifestations of disease that don't seem to fit a classic disorder, I'll particularly go towards genomics. And secondly, it's allowed me in a couple of patients to touch on targeted therapies for cancers that are very aggressive, that have really exhausted all treatment options, and I've been able to find treatments that hopefully should be geared towards them. So that's how I've clinically used it at the moment, but there's a whole heap of potential for future clinical practice. So previously, you try to fit the phenotype to a particular gene and get that test done. And if you're lucky, that one comes up, but it may not. And so you could spend years going through genetic testing with single genes. And sometimes you can label somebody as having a particular disorder, and lo and behold, when you do wider genomic testing, you can actually uncover that there are multiple genes involved. Sometimes it's easier just to ask the whole exome or the whole genome what the story is. So I had a patient who had been known to have multiple endocrine tumours. She'd had one or two genetic tests, looking at just single genes without any answers being found. Really, to find an answer, we needed to go to the whole genome, or actually would have been fine to go whole exome. So we did, and we found a mutation in a gene. We could fit her phenotype, but she wasn't classic. And so that led to a change in her management and pick up of a whole lot of other conditions within her. So we've got all this brilliant technology, and we can spit out a heap of data, and you can find lots and lots of variants. But what is majorly lacking is being able to link that with the clinical interpretation relevant to the patient. So in my particular line, where I do a lot of research in disorders perhaps not very well genetically looked at and characterised, I find a lot of uncertain variants of uncertain significance. We find a lot of conflicting data in databases about what that variant means. Other problems that I see arise from that in terms of clinical challenges is, because you have all these variants where you're really unclear about it, is reinterpretation of variants. So when should you do that? Do you do that in a year, every year for all of your patients? Do you do it 5 yearly for a batch of patients? How do you keep up with the changing genetic knowledge about different variants? I also think that the health system is going to have massive challenges with access to data. So once patients have had genomic testing, what do we do about accessing that data for other disorders that they may have, for other presentations to other hospitals? How are we going to resolve the privacy and security around data? It's allowed answers. So in cases like that lady I described, she went for many years with people wondering about what she had. But it's also allowed the real opportunity to practice personalised medicine. So when you can actually know that there's potential treatment out there that can suit your patients.